with you all. Okay, let's get there first. First of all, I'm sure most of you have already seen that the December 15th Board of Health meeting will give us the final vaccination rules. So I've scrubbed that through a little bit, and we'll post something on my blog for the members of CHCA. So if any of you are subscribers, you'll get this information, but and you can of course read it for yourselves. But it looks like they've adopted pretty much everything that we all had sort of a consensus about, which is fantastic. It looks like CDPHE has done a lot of work on this, to be expected, of course. And it looks like they've exempted the in-home caregivers. They've unified the medical and religious exemptions to treat them the same, which was the one that my little personal axe to grind. So I'm glad they did that one. So no more waiver requests. That's exciting. Also, they have rectified some of the reporting confusion. So now we have a date range of the 1st to the 14th and the 15th to the last of the month. So that's fantastic. The need for us to have a plan to encourage people to booster is included, which we expected and is not a bad thing, obviously. They're lumping the use of MABs and previous 90-day infection into the medical exemption so that you can actually document when people have a period under which they cannot vaccinate. And they've addressed the new hire issue across the board, both for exemption eligibility and for what allows them to begin work and is considered acceptable. So they are supposed to have at least one dose by the time they have client contact, and they are treated as unvaccinated until they're fully vaccinated, of course. So that's not a surprise, and that's the direction we've been getting from the department. So it's just really nice to codify it all and know that we all have one document to look at. So that's exciting. Also, I wanted to touch on, many of us have been experiencing people wanting recognition and wanting to recognize those that are continuing to be very diligent in fighting COVID within their buildings and implementing infection control. And Telligen has recognized this need and created a really nice product for us to use free of charge. And I just wanted to alert everybody, we're putting out a blast to all of our members today. Colorado is not yet very well represented yet in this program, but I imagine it will be a fairly quick uptake. So it's called their Blue Ribbon in COVID Vigilance. And facilities complete a self-assessment, then they receive a customized printable certificate to post in their building. And it says that they are in receipt of a blue ribbon for COVID vigilance. If they don't answer yes to all of the self-assessment questions, it just transmits information to Telligen so that they can reach out to the facility. So it's kind of a dual purpose. We all love to have Telligen's help free of cost, of course. It's wonderful that they do all of that. And then they have tacked onto it an extra special free social media package that facilities can use to publicize that they've gotten this recognition. So that to me is taking this really the mile that we wanted them to go, or that we wanted someone to go, that we all hoped would happen. It's a little bit more than we could have done probably as some of our smaller committees that have been jabbering about this need for recognition. So I was just thrilled to see this. The threshold for participation is vaccination. So they need 95% vaccination of residents and 85% vaccination of staff to be eligible for the blue ribbon. So some facilities might have to catch up a little bit before they're eligible, but I think most buildings will be there already, which is exciting. So, and then I just wanted to touch on a couple of tidbits that we had received, and maybe Chad can speak to this further. The federal oversight surveyors apparently have tagged a facility for not cleaning eye protection, face shields between COVID tests. And so I don't know if that's something across the board that we are seeing, but I wanted to mention that because if it is a need to change our procedure instead of treating it basically as an aerosolizing procedure, maybe. I'm not sure what the justification was for it, but that raised a red flag for my buildings, talking to me about the recent deficiencies. Also, we've received some positive feedback on staffing tags not being quite as readily cited because the state is making an effort to see what facilities are doing to allocate the staff that they do have. So we're continuing to advise our facilities to copy that and document all of their efforts. And then also, like I said, the reporting has been adjusted. So hopefully the IDRs that are underway for reporting tags can be fixed at this point with direct conversation with CDPHE, which it looks like they've been really open to doing. Quick note on that as well, there is a bit of a glitch. Sometimes facilities are not using Google Chrome when they submit their reporting data, and the state is saying that they cannot necessarily receive it if it's in an improper browser format. So that's something to watch for. I know my facilities are actually taking images, pictures of, or screenshots of their submissions so that they're able to present that they actually did submit. But again, that's ending up as an IDR for reporting deficiencies. So that is the latest and greatest on all that. As far as CHCA happenings, we are still pursuing our draft legislation regarding agency usage and pricing. So that's in the works. The board is reviewing drafts at this point and deciding how we're going to pursue that in the first part of the legislative session. So that'll be between January and April. And additionally, we're working on our education offerings. That is becoming pretty broad reaching at this point. So we will be doing a training on sexuality in elders and sensitivity to LGBTQ issues in elders. So 2 separate trainings on that. We're working with our ombudsman on those programs. We've had several more requests for IDR training, so that continues to be a favorite. And then we are setting up for our fall or our spring conference and our assisted living conference, which will also be a 1-day in April. We've been well received by the Occurrence reporting side because we are asking them to collaborate with us along with CDPHE in retraining on abuse and occurrence reporting. We did a big training on it a couple of years ago, and it was very well attended. We're going to try to duplicate that in some form or fashion in this coming few months. So stay tuned on that one. And that's it.
Thank you so much, Jenny. If people want to follow your blog or receive it, how would they get there? Could you put it in the chat?
It's for our members only, but I will post the member login so that you all can see it in the chat.
Thank you so much.
Mm-hmm.
Chad, do you want to give us an update from CDPHE?
Sure. So
Thanks.
yeah, just really kind of just a few things. As far as doing survey, we received some recent updated guidance with respect to the types and frequency of surveys that we'll be conducting. We've had something of a soft reset, I think. You know, we've had this really an incredible backlog of facilities that need to have their recertification. Some of them have gone on into the 20+ months since their last recertification. And I think the intent here is to keep that backlog from growing. So we're going to be going out to some of those facilities that have, you know, they're in the 13 to 14 month time frame, so that they won't fall into that overdue category. And then as part of that management, then we would also look at conducting some of those surveys that are for facilities in the backlog, you know, so making sure we're not exceeding that 15.9 month threshold. And we'll be selecting those facilities based upon their history of allegations of noncompliance with, you know, kind of the heavy hitters: abuse, infection control, violations of transfer and discharge requirements, staffing issues, and other quality care issues, falls, pressure wounds, and the like. As part of helping make this more manageable, we have some facility tests that we complete when we go out on survey that are temporarily will become discretionary. So if we see issues related to resident concerns, visitation, grievances, we will conduct the resident council meeting, but otherwise we're going to be visiting with residents through the initial stages of the of the visit and make some, determinations with respect to the facility's compliance with those kinds of things, the kinds of things that would otherwise come through resident council meetings. Dining observations we'll continue to do, but specific to residents with weight loss concerns, issues with nutrition, perhaps dialysis, and med storage. Med storage we'll take a look at if we've identified concerns during the medication administration facility tasks. So that's not to say we won't be doing those, but we have some discretion as to, including that in the survey, all in the, with the intent of helping the facility move along, efficiently. We'll be combining, as we've done to this point, as many, kind of serving dual purposes, looking at facilities that have a number of complaints so that we can manage the complaint workload along with the completion of recertification surveys. And one of the things that has been brought to light, and I think we've focused on it anyway, but has been brought to light with the new direction from CMS, and that's that we're going to be looking at, being aware of potential areas for further investigation related to nurse competency. And when I say nursing, so, this would be your CNAs and your nurses as well. The inappropriate use of antipsychotic medications. We've seen an increase through the pandemic of those types of medications being used. So we'll be looking at that. And then other areas of concern where health and safety may be at risk. And so these are things like unplanned weight loss, loss of function and mobility, depression, of course, abuse, neglect, and pressure ulcers, those kind of things. And, Jenny had brought up a couple points, I think, in terms of our finding and the severity of some of those findings. And we have seen continued pressure-related facility-acquired and avoidable stage 4 pressure wounds. Systemic failures with the infection prevention and control program. And we've had immediate jeopardy findings with respect to COVID testing. We've had that at a few facilities and have had a lot of other conversations about how to proceed with others. And at the end, I'll address maybe perhaps some of those points and questions that Jenny had brought up. Also, continuing to see immediate jeopardy kinds of issues around accidents, whether that is the not providing the support that people need, or perhaps it's supervision. We've had a number of citations that we see more frequently. And the list is probably something that would be consistent with some of the other things we've talked about in previous meetings and in other meetings, things like, the abuse. We're looking now at the right to receive and deny visitation. We've seen some citations around that with respect to, response to CMS's QSO 2039, where, if I could say, the visitation requirements are much, much more liberal. Essentially everybody should have the opportunity to have visitation, and this may be, regardless of the outbreak status of the facility. We want to be reasonable when we take a look at these kind of things, and we would be asking too to make sure that, with the visitation being opened up as it is, that we're looking to see that facilities are being responsive to the needs of people, to making sure that others, the resident and others, are, have safeguards in place to make sure that the transmission of COVID is still being addressed while allowing that visitation. We continue to see ADL issues for dependent residents, nutrition, hydration, pain. We do see some issues around sufficient nurse staffing, and that too is something we want to be sensitive to, because we do understand the concerns that are out there around staffing shortages. When we start to see patterns affecting overall care across a number of areas, so it starts to build this greater concern, then we're more likely to further investigate and look at the relationship between staffing, not only in terms of numbers and being able to provide care, but also the competency of the staff providing the care that they're capable of providing, with respect to the training that they've received or their experiences. Of course, dementia care a lot of times goes along with seeing citations with abuse, particularly with resident-to-resident situations. Kitchen, significant medication errors, QAPI. We continue to see citations with respect to QAPI, but those and with respect to the blanket waiver around QAPI activities, when we're citing that, we're seeing the direct relationship between concerns with QAPI and those things that are being called IJ or have the serious adverse outcomes related to the concerns that we're identifying during the survey, and that part was not waived in the 1135 waiver. Still looking at the most serious of situations and developing approaches and plans around that, addressing those concerns. Jenny
Chad, this
mentioned
is St. Pallet. Hi. No, thank you so much for your diligence. And it's really great news to hear about the facilities feeling like the staffing tags aren't as stringent. We appreciate your understanding. It's such a tough time. Are there any questions for Chad at this time? I just want to make sure we have enough time for the other updates.
I did want to add one thing, and I'll do it very quickly.
Sure, thanks.
As far as the concerns around the infection control and doing things like wiping your eye protection, I don't believe that ended up being included in the 2567. And in conversations with that, we also want to be reasonable, and we would expect to see that eye protection would be cleaned if there was reason to believe that it became soiled or contaminated in some way during the process. So we will be having those conversations at our office and making sure that we are approaching that with consistency.
That'd be great. Yeah, there's probably some confusion from place to place. So thank you so much. And thanks for all your work at the CDPHE. We have another announcement, Dr. Greg Gahm.
Oh, mine is going to be simple. Just to talk about influenza, I sent out a couple updates. We are really well below what we would be in a normal season for right now. So even though there have been some sporadic reports in at least one facility last weekend that had 4 patients with flu A, we are nowhere close to having an outbreak here yet. So it is time to have everybody vaccinated. Just make sure that's done. And I'll keep tracking it, send out note if it increases.
Short and sweet and good news. Yeah, thank you. Thanks, Dr. Gahm. Well, we have invited Dr. Lea Watson, geriatric psychiatrist, to come and speak to us about some diagnosis issues, specifically regarding psychiatric issues like schizophrenia and prescribing. Dr. Watson, are you on?
I'm here.
Oh, hi.
Can you hear me?
Yes, I can. I can see you. Thank you.
Great. So I think, and my co-host, I should be able to share my screen, correct?
You should be. Yes, it says you're our co-host.
Let's see. Here we go. So this is a little tongue-in-cheek because my teenage daughter is trying to get me to use newfangled media. So this is an interactive thing they use in high school. So it's supposed to be sort of funny, but we're going to talk about Travidol first. So for those that work with me, you know, I hate to see people use Tramadol for a lot of reasons, and I never have time to describe exactly why. And let me make a disclaimer that I am not a pharmacist or a pharmacologist. I'm an opinionated psychiatrist, so take this with a grain of salt about what that means. Let's see here if I can get this. Let's see, full screen mode. There we go. So this is what you make sure you have before you start. So this is a lesson that says to come with an open mind, please, when you're listening to me talk about Tramadol. And really, as a preface to all this, it goes without saying that we should know why we're using opioids to begin with. So have a good justification for the use of opioids, which are frequently overused in the long-term care space for chronic pain that is not acute or not cancer related or end of life rated. So understand when you're using it, and you have to come to this presentation with an allergy to writing PRN prescriptions for chronic opioid use. That is also a joke. Okay. Let's see here. So what I hope you'll come away with this brief talk here is just to understand the risks of Tramadol if you don't already understand them, and just to stop reflexively prescribing Tramadol as a safer agent, because you'll learn here that it is actually not safer. So what is Tramadol? It's actually a synthetic opioid with a dual mechanism of action, which is what makes it tricky.
We're still on the main title page. Is it supposed to be on a different slide?
Yep. It says sharing is paused. Bring your shared window to the front.
What I see too is the title slide.
I don't know what that means. Well, I guess I can just talk. Let's see, resume share.
Do you want to like unshare and then share again and see if it kinks itself out?
Let's see. One participant. I don't know how to unshare.
It should like pop up and stop sharing with that little red.
A red box at the top.
Yeah, I see a little red box. It says one participant can share at a time. Oh, stop share. Here we go. All right. Sorry, guys. I can also just talk through this if it becomes too cumbersome.
Singh, do you have a copy of Dr. Watson's slides that you could share?
No, not yet.
Yeah, I sent them right before the
okay.
talk, but I tell you what I'll do, because I don't want to waste people's time, is I will just pull this up on my own screen and I will just tell you what it says, which will be easier than the other way around. Okay. Sorry, everybody. If it can be technically challenging, I am the person for the job.
Thanks for troubleshooting.
So for those that are unaware, Tramadol was approved in 1995 originally as a non-controlled substance. It is a synthetic opioid that's centrally acting, an oral agent that actually has opioid activity. It was actually rescheduled in 2014 because of growing concerns about abuse, misuse, addiction, overdose. So it basically functions just like any other opioid with regard to risk. It has street value, people overdose on it. It is dangerous. It is no safer than other opioids. Let's see here. So the main reason that it is problematic is because it is highly polymorphic. So there's a prodrug, which is actually an SNRI, so a serotonin and norepinephrine uptake inhibitor. It goes through first pass metabolism through the cytochrome P450 system, the 2D6 pathway, and then the secondary compound is actually a mu1 receptor agonist. So that's where the opioid activity comes in. So if you can just picture my beautiful slide, it'll be like SNRI goes through the P450 process, goes to the opioid agonist, right? And so, and people have highly variable responses in their P450 system. So you can be a fast metabolizer, a slow metabolizer, or an ultra fast metabolizer, which is particularly dangerous. So this is where we get into trouble. So if you metabolize too quickly, you can have sudden increase in opioid activity, which can actually cause respiratory suppression and death, which is what we all worry about with opioids in general. But as a fast metabolizer, it shoots over by that first pass metabolism and gives you a big dose of that M1 agonism. If you're too slow of a metabolizer, you actually have an increase in the SNRI parent compound, which can increase your risk for serotonin syndrome, and then actually does not do what the intention was, which is to reduce pain, because it never makes it to the other side of the equation. The third main reason that it's so unpredictable is because of its P450 metabolic pathway. There's many drug interactions with Tramadol because it's a major pathway for other drug metabolism, especially psych meds, which is why I'm interested in it and why I see so much trouble with it. Tramadol is known to interact with drugs that are affected by P450 enzymes, specifically the ones that affect 3A and 2D6, which I don't expect you to remember, except for just know that most all SSRIs and TCAs and MAOIs all go through this pathway. So it can affect blood levels of Tramadol or of the active metabolite of the other medications, and in many cases can be dangerous or fatal. And I have seen people die of a Tramadol overdose with their very first dose of a medication, for those that are wondering about anecdotes. And it actually happens in children as well. The other thing that happens is side effects are increased for use of Tramadol, especially in the elderly, including that it lowers the seizure threshold and can cause serotonin syndrome. So just comes with a fair amount of risk. And the reason, of course, it's particularly bad in the elderly is because it has all the risks of opioids, which we hate in the elderly in general, and it increases seizure risk. It can actually cause hypoglycemia. It is renally excreted, so must be dosed that way. And because the older you are, the more medications you're on, the more likely you are to have other drug interactions. So the main takeaway points here are: it is not a safe opioid. It's certainly not any safer than any of the other opioids. It has a very unpredictable metabolism, increasing the risk for death or ineffectiveness. So on both sides of the equation, there are serious drug interactions, especially with psych drugs. And there's worrisome side effects for people that are older, including seizures and hypoglycemia. So I know someone's going to ask me, so what should I prescribe? And I'm also not a pain doctor, but in my practice and in helping you guys through this a lot, low dose Percocet or low dose hydrocodone are far safer and far less unpredictable if you can justify the use of an opioid in general. So that's what I would suggest. And of course, make sure they actually need one. Use long-acting if they need it, if they're at the end of life. Consider other reasons that might be causing distress and all of that. But I hate to see Tramadol used. If people come in on it and they're stable and they're doing okay, I don't see the reason to necessarily stop it unless you have a clear drug interaction. But I certainly wouldn't start it. So I'll stop. I'm sure people have some questions about this before I talk about schizophrenia. Any questions?
Lea, are there some specific medications that you like to watch out for interactions for when people are on Tramadol? Is it just the SSRIs and SNRIs?
Yeah, SSRIs, SNRIs, TCAs, MAOIs, and then all of the drugs, some of the anti-epileptic drugs, including Tegretol and Trileptal, are also very much influenced by Tramadol, and their levels can be disrupted. So all the anti-epileptic drugs and any psychiatric drug are my main considerations. Also, other drugs that we don't use as much anymore, like ketoconazole, erythromycin, all the drugs that go through that pathway. Good question, C. Anybody else? Cool.
If you want to try to share your slides again,
you know what? This one is just a document, and I did send both of these to you, Sing, and you can send out my cute little school grade PowerPoint equivalent. And then I had this document. Actually, the one I'm going to discuss is an executive summary that Amda, big Amda, put together a few years ago that we just released again about schizophrenia diagnosis in long-term care because of the overuse of schizophrenia diagnosis recently to justify the use of antipsychotics. So for those that didn't see it, there was an article in the New York Times a few months ago that was quite revealing and upsetting regarding the increased use of this diagnosis, basically to get away with using these drugs in people with dementia. And so I won't go through the details of that article. It's readily available. We've sent it around before. I did a podcast on it for Amda for those that are interested. But let me just take that. The whole point of this update is basically to remind you that schizophrenia does not happen in old age, typically at all. The comical thing about the study of very late onset schizophrenia, those of us that are my age and older will chuckle at the thought that late onset schizophrenia is thought to be at age 40. So it's certainly not going to be at age 80 or 90 or even 70, and rarely at 60 and 50. So suffice it to say that diagnosing someone with schizophrenia for the first time ever at age 80 is like a humongous red siren going off that you're doing something wrong. You can have psychotic symptoms for many reasons in late life, typically from a delirium or a dementia. And I'm actually going to talk about this at the annual conference this year. So when psychosis is a unifying diagnosis, for symptoms, there are many different pathways that can lead someone to have psychotic illness, and schizophrenia is rarely one of them. So I'll go through here briefly. For those of you that don't know the diagnoses for schizophrenia, you have to have 2 or more of the following present for a significant portion of time during a 1-month period, at least for first onset or greater than 6 months. And it typically happens in late teens to early 20s. It includes delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. So the key to diagnosing schizophrenia actually is not the positive symptoms so much as it is the negative symptoms. And for those of you that take care of people or know people with schizophrenia, you know they're really characterized by that flat affect and their inability to engage socially. And of course, all of these symptoms have to have what we call in psychiatry a B criterion as well, which means that it impacts your life significantly. So I won't go into the details, but just remember that the first episode is usually in the late teens to early 20s, and it doesn't happen in old age. And I think there's going to be, you know, Chad can weigh in, or others that are on the survey side of the house can weigh in about what their thinking is with this. But in conversations I'm having at a national level, there is some real concern that there's going to be greater scrutiny about this with some consequences. So I think obviously we want to practice good medicine is the main reason. And the other thing I'll just say is that if someone has unprovoked aggression or severe psychosis, even if they have dementia, we can justify the use of antipsychotics, and we do it all the time for a short amount of time if the person is actually in significant distress or there's a safety issue. So it's not like the medications can't be used. Through all of our antipsychotic reduction initiatives and our dementia partnership, I think we've done a great job of learning how to use non-pharmacologic interventions, but there are times for sure when antipsychotics are indicated and they're well justified. And don't let staff or other, competing demands tell you that you have to use this diagnosis. And I'm sad to say that I get a call not infrequently from a really stressed out DON saying that her numbers are too high, and she really wishes that we could change the indication for the medication to something else so she wouldn't have to report it. And as a reminder, the only indications for which antipsychotics are not so highly scrutinized are for schizophrenia and Huntington's disease and Tourette disorder. So if it's outside of that, the facility staff feel a lot of pressure to keep their numbers at a certain level, and this is no one to blame here on the facility side. Everyone's just trying to keep their jobs and do the best. And I guess my feeling, and I talked about this in the podcast, is that whoever wrote the prescription is the one responsible for the medication. So as prescribers, please know that if you're calling in a verbal order, you need to be really specific about what your indication is in case someone might take liberty with that on the other side. So I'll stop there, see if there's any questions and try to keep you on time here.
Are there any questions for Dr. Watson? There's a comment.
How do you recommend we document when they come in from hospitalizations and things with either a schizoaffective or bipolar disorder, where there seems to be probably a community standard of care that some patients with schizoaffective and bipolar function better with antipsychotics, and where much of the outpatient management preceding the nursing home admission isn't known to us. And so, and much of it we can't even find out unless a good PASSAR level 2 has been done. So could you comment on schizoaffective and bipolar use of these drugs?
Yeah, that's a great question, Lee. So diagnostic clarification is the most important thing, of course, and we often do not have the history or family available to help us understand the situation. Typically speaking, when someone has a schizoaffective disorder, they, I would say more often than not, do have a history of a chronic psychotic illness. So when you see that diagnosis and they come in on antipsychotics, my first reaction, and Dr. Gahm and I tease each other about this a lot, my first reaction is to not stop them, because typically people with schizoaffective or schizophrenia, somewhere in the record, almost always have some history of a chronic psychotic illness for which stopping them would be very disabling. Bipolar disorder, on the other hand, gets tossed around all the time and is especially commonly misused in people with borderline personality disorder, in people with substance use disorders. So anybody that acts a little bipolar or a little manic, somebody will slap that bipolar diagnosis on them, and it's not always accurate. So schizoaffective is a little more sophisticated in the vernacular of psychiatry, and so people don't throw that one around as much casually. Bipolar disorder, they do. So you really have to check. This is not unlike people will sometimes use mood stabilizers, for instance, let's say Depakote, and they'll say it's for seizures, and the patient's never had a seizure in their life. There's no history of seizures. It's just a good reason to put it on the chart. So as always, the best thing to do is to get as much history as you can and to look at the patient and see what they look like and try to sort it out. But when someone comes in with a schizoaffective who has been homeless and has a history of substance use, and we know has had psychiatric hospitalizations in the past, I definitely default on the side of believing they have a chronic psychotic illness. If it's a brand new diagnosis at age 80 and they don't have these negative symptoms and they have a different history of work life that does not jive with a serious mental illness, I feel fine telling you guys to take that off the chart. It's also a great time to promote the fact that we should really consolidate diagnoses. I can't tell you how many problem lists have all of the above. So major depression, major depressive disorder short, major depressive disorder long, schizoaffective, bipolar, adjustment, and you really can't have all those things at one time. So any amount of diagnostic clarification you can bring to the table is super helpful, both on the facility side and on the ICD-9 side for billing purposes. So I would have a little more liberty in doing that if I were you all, to be honest, than I see you taking. There doesn't have to be some magic wizard of psychiatry that comes in and declares that they do or don't have something if it's completely obvious to you. For instance, you can't have adjustment disorder forever, right? It's a short-term thing. So feel free to switch that over to major depressive disorder using your own clinical judgment. You don't have to always have a PASSAR or another psychiatric involvement to do that. So just to empower you to do that. Good question, Lee.
Very good, thank you. Are there other questions? Thank you so much, Dr. Watson. I'll be happy to share the slides with everyone. Apologize for the technology issue. Our next presentation is about the booster vaccines, and Dr. Leslie Eber, who helped cover for me when I couldn't make it to this meeting on time. Thank you so much for doing that. She's also prepared a presentation on this subject, and she's done a lot of work with Amda to promote vaccines and boosters now. But thank you so much, Leslie.
Thank you very much. Thank you so much, Leah. That was so awesome, very helpful. I'm hoping that my sharing slides is working. Okay. So boosters, I feel like it's our latest challenge. And I think that there are some data that we are learning about, which can maybe help us out, thread that needle. Hold on a sec. So what are we hearing about the current barriers for COVID-19 booster shots in our space in post-acute and long-term care, specifically from staff? And this was a casual survey done via Amda in the last week. And what are we hearing for the reasons why staff are not getting their boosters? We've already had COVID-19 infection and the vaccination. Truly, surely, I do not need a booster. A lot of apprehension about side effects. Everyone remembers there was a second, especially if it was a messenger RNA, of course, vaccine shot, and it really wiped you out, and people don't want to go through that again. That's the most common reason throughout the United States that we're hearing about. Is it really needed? I am, quote, fully vaccinated. I don't want to take time off from work. It's hard to make an appointment. I have to say, getting booster shots outside of our facilities seemed to be really challenging. I was forced to get the vaccination. Boosters are not mandated, so it's my choice. Okay. So what are some current strategies that may help us out? And this is from a Lancet article that I found really helpful. And so the reference is below. Keeping booster shots in the forefront of people's minds. Reminders, posters. I'll show you a poster from Amda that I really like. In-service, having a lot of booster clinics and education, and then framing the message appropriately. There's an article I'm going to show you at the very end. I just found it today, that your risk of breakthrough infection without a booster, when a booster is needed, goes up from like 1.6 to 22%, that risk. And so really having people understand that breakthrough infections are happening, especially with Delta. We don't know what Omicron will bring, but getting your booster really will not only protect you and your family, but the residents. And this last Lancet article that I'm going to show you talks about folks who are over 60 and the risk of reinfection when they don't have a booster. Of course, our actions matter. And what about presumptive communication? I really like this idea. I'm going to fold it into how I do my education in our space. There's participatory, would you like to have a booster shot, versus presumptive format. You are due for your booster vaccine and we are having a clinic this week. Can I put your name down? Of course, opting out framing is much more effective than opting in. If possible, of course, remove the barriers, have multiple booster opportunities, make sure your staff knows that if they do have a side effect, they will be able to take some time off. Incentives is an interesting idea. It seems like monetary incentives have not really panned out the way we thought that they would. The most famous one that was published in JAMA was from Ohio, and they found that offering money did not really thread the needle. But here in this JAGS article, in terms of encouraging nursing home staff to get their COVID-19 vaccine, non-financial incentives did work. So it's something to consider. So booster education. So we have added some things about our updated booster information sheet, which is on the Amda website. We also folded in when you should get your booster. If you've received monoclonal antibodies, it's different if you received monoclonal antibodies for prophylaxis versus for treatment. Answering the most common questions that people have, come to the table with these questions already in your back pocket and the answers. Do I need the booster shot? About the side effects? What about new variants? And what about breakthrough infections? Here are 2 recent articles, and I just put their links with them that I found compelling as, again, to put in my back pocket to explain to folks, why do we need boosters? And so that's always really helpful. I found these to be really helpful as well. Here is the Amda booster poster. So it says, these days, everybody deserves a boost. I can relate to that. We want to make it present and informative and encourage people to get their boosters. And then I just found this article today. I thought I'd just put it up here. I'll send out these slides. It talks about, again, breakthrough infections in older folks. These are our patients and what their risks are if they don't get boosters. So that boostering is really helpful. So I'm happy to answer any questions. Really want to encourage everyone to promote boosters. I think if we stay silent, we are going to see what we are often seeing right now, which is a lot of breakthrough infections. But we have an opportunity to really make a profound difference. So that's my plug. Any questions?
Thank you very much. Is that last article, Leslie, the one that talks about the relative benefits of the booster, the extra protection, and quantifies it?
It does, I haven't gone through it fully because I just found it this morning, but it just really talks about, it was done in England about older folks and those who are hospitalized and seeing how the increased rate of reinfections happens when they did not get their booster. The relative risk, I think, is best seen, I can bring it up on that second slide in that second JAMA article. I think I think it's 86% decrease in getting a positive COVID test when you get a booster versus you don't get a booster. So 86 decrease %. I hope that answers your question. I'm not sure if I did.
Yes, thank you.
All right, well, thank you very much.
Yeah, thank you. Are there other questions for Dr. Eber? Well, thank you all so much. We had a lot of great information here today. And I will be sending out the slides to the entire CMDA distribution list. We have a little bit of time. If other people think of questions for any of our speakers today, I'd be happy to have a discussion. And we were supposed to have a CHF presentation today, but that's been moved to January. So we're finishing a little bit early. Just a couple of announcements. The Amda National Conference will be held in March in Baltimore, and there's an option to attend it remotely or live with the same registration. The early bird registration ends on December 21. So if you want to go and save some money, please get onto the website and sign up. We are also in the middle of preparing our own annual conference. The CMDA annual conference will be held in April. That'll be here in Denver. We'll come up with more details about that soon, but the date is April 29th of 2022. We're very excited. We're going to have a great conference again this year. One more announcement is that Galen Hartzweiker, Allison Villegas, physician assistants who serve on the board for CMDA, who were hard at work last month working with me to start a CMDA podcast. First ever podcast episode was recorded last month. We discussed the management of DVTs and talking to providers about what issues come up when we're taking care of DVTs. It's just an interprofessional discussion, and we have it posted on our website. The plan is to pick other topics that come up from time to time that would be helpful for us to discuss as providers and with our interdisciplinary teams, and make them available to anyone who wants to listen. So take a look at that when you get a chance. It's only 15 minutes long, and hopefully in the next coming months, we'll have some other podcasts available. Our next CMDA monthly conference or meeting will actually be the first week in January, January 4th. As I mentioned, we'll have our CHF presentation at that time, probably a couple of other speakers, including our standing updates from CDPHE, CHCA, and Dr. Gahm. Other questions for any of our speakers today or any comments?
This is Christine LaRocca. If I could just say that for homes that are maybe want some as always, no cost assistance with their vaccination rates. I hope they know that Telligent is here to help. We have a podcast series that was presented by nursing home leaders. So it's peer-to-peer from homes that achieved high vaccination rates from across our 4 states. We have a Medicare beneficiary to Medicare beneficiary podcast of why people chose to get vaccinated and what their experience was with the vaccine. We have all kinds of resources and are thrilled to help, especially as we are now moving into boosters.
Thank you. Sounds like you're taking several approaches to that kind of outreach and education. And thank you for making that available through Telligent.
Can I just chime in that that JAGS article also promotes what Dr. LaRocca was just speaking about, which is this multi-pronged approach to vaccination. Usually it's not just one thing that you do, it's several things. Maybe you're doing posters, you're doing some in-services, and you're offering, I don't know, t-shirts or a Starbucks gift card, and you're having your leadership also talk with staff on an individual one-on-one way. So I think that multi-pronged approach is really helpful.
Makes sense. So thank you, Jenny. Jenny Albertson's put in the chat box that the strike team and immunization branch, this is through the CDPHE, are contacting all facilities with a 75% or less booster uptake for those that have not reported to assist with reporting and education, etc. It's great. So I'm glad the state is doing a targeted approach for that. If anyone wants to share their story about how vaccination is going in their facilities, we welcome that, of course. And otherwise, we look forward to seeing you again at the next monthly meeting on January 4th. And happy holidays to everybody. Thank you so much, everybody.